This session is titled Implementing a Closed-Loop Social Care Referral Platform to Address NMDOH. CommUnityCare is one of Texas's largest FQHCs, serving 134,000 patients in the Central Texas region. This webinar covers their experience building a holistic approach and implementing a closed-loop referral process to address patients' non-medical needs. We'll learn about how CommUnityCare developed a process and community engagement to maximize uptake of this tool among patients, staff, and community-based organizations. We will get an overview of the process for workflow development, training, and dissemination. Our session today is presented by Carmen Cardenas and Clarissa Banks. Carmen is the Associate Director of Population Health Management at CommUnityCare. She's a devoted registered nurse, having spent 18 years building, scaling, and optimizing programs that create bridges between patients' health and social needs through pioneering population health strategies. Her motivation, fueling her work, is her deeply rooted in her upbringing in the very communities she is now honored to serve. Thank you, Carmen and Clarissa, for being here. Over to you, Carmen.
Thank you, everyone. Again, thank you for joining us today. Before we begin, I want to introduce my colleague, Clarissa Banks. She, her, is a dedicated social worker with a bachelor's and master's degree in the field, complemented by her certification as a community health worker. Her expertise lies in addressing the social drivers of health, aiming to improve community well-being and advocate for systemic change. Clarissa's work is driven by a passion for social justice and a commitment to creating sustainable health outcomes. She is known for her innovative approaches in the realm of population health management, utilizing tools and platforms to create actionable strategies. So my colleague, Clarissa. Before we begin, please note that we do not endorse any specific platform. We use the Find Health platform. Our goal is to equip you with the tools and knowledge to evaluate any platform you may be considering. Also, you may hear us use the term social drivers of health and non-medical drivers of health interchangeably. We're still adapting to the new terminology. I'm going to briefly cover today's objectives. We will discuss strategies for implementing a social care referral platform that engages community-based organizations, facilitates the exchange of and tracking of referrals, engages individuals in the community-facing social care referral platform to promote self-management, and discuss leveraging platform analytic tools to drive interventions. Who we are. CommUnityCare is the second largest FQHC in the state. Our clinics provide approximately half of the local safety net primary care services for our area. We operate 28 locations throughout the Austin-Travis County area and 1 location in Bastrop. In 2023, CommUnityCare served over 134,000 individual patients, accounting for more than 491,500 medical and dental visits. Of the patients we served, over 78% live at or below the 200% of the federal poverty level, and 61% prefer to communicate in a language other than English. Our mission is to strengthen the health and well-being of the communities we serve, with the focus on equity, quality, community, resourcefulness, and workforce. You'll find that 2 precursors to implementing a social care referral platform is to screen patients for non-medical drivers of health and have roles within the organization to intervene. With that in mind, I'm going to begin by providing some background on our population health management initiatives. In 2018, I'm going to go back a little bit. We've been screening for non-medical drivers of health since 2017. In 2018, we welcomed our first 3 community health workers. April of 21, we went live with our new electronic health record and patient portal. And we were fortunate enough to implement our social care referral platform in July of 2022. This slide speaks to the different CHWs and scope of work within our organization. Our CHW positions are funded by a combination of grants and operational budget. We discovered that grants frequently enable us to hire CHWs, showcase their impact, and subsequently inform decisions to integrate community health workers into the operational budget. The scope of work for community health workers differs across our organization. Our community health workers are not in the community in the traditional sense. You'll find them sitting shoulder to shoulder with our providers, nurses, intervening in non-medical drivers of healthcare, assisting with healthcare navigation via warm handoffs, and referrals via electronic health record. You'll see them providing patient portal enrollment and supports, engaging community partners in conversations about our social care referral platform, or teaching team members how to connect patients to social resources. They can be seen leading centering pregnancy groups, completing prenatal touches with OB patients, teaching a healthy chef class, or assisting a patient to make a successful transition from a hospital admission back to their primary medical home. I know this is a really busy slide. I'm going to focus on the 4 phases. We hope that this serves as a tool as you go forward in duplicating and doing the work that you do around a social care referral platform. Our implementation process commenced with a mindful assessment of various platforms. We considered factors such as platform adoption rate in our service area, the integration capabilities into our electronic health record, analytic tools available, and vendor support. We also opted to integrate both our own community-facing and team-facing platform. We'll speak to those in future slides. The platform workflow development was followed by a phased approach to training and dissemination. I'll provide an overview of each phase and call out some interventions that we feel are crucial. In the initial phase, we prioritize training care team members that address non-medical drivers of health as part of their current scope of work. So these were our community health workers, care managers, social workers. We identified priority community-based organizations based on team member feedback. This step was essential for securing buy-in for the project. We incorporated training that supported all learning types, but we saw the most progress when we completed real scenario practice sessions and refresher training. During our second phase, we launched a targeted outreach campaign to promote the community site to our patients and the general community. We incorporated communication that supported different communication preferences. We ensured to document the date of the campaign interventions to review for correlations with data. In phase 3, we focused on training remaining patient team members on the platform with modified workflows and scope of work expectations based on each role. We piloted in different service lines, and we also made sure to take the work through our care model committee, which establishes our gold standard workflows across the organization. In phase 4, and this is the phase that we're currently in, and then this phase is in progress. Our aim is to improve our CUC program listings and accept inbound referrals. We're inviting community-based organizations to collaborate with us on our platform. However, we recognize the importance of understanding and addressing their needs to ensure a successful partnership. So the question becomes, what support or resources do the community-based organizations require from us? One intervention that I will highlight here that I think is critical is our community engagement lead. Our strategy was to appoint a community engagement lead and now, thankfully, a community engagement coordinator. Both of these roles play a pivotal role in each phase of the implementation process. I have highlighted our approach and strategies. Clarissa will provide more detail. This slide here provides a visual presentation of our implementation process. It's designed to support your own implementation as a reference tool.
Thank you. Looking more in depth at specifically what we implemented, we'll start with our staff training. To train over 1,000 staff, we started with an in-person training for our population health management department, like our CHWs, social workers, care managers, etc. We identified that these staff are the ones placing the highest number of referrals to community-based organizations, or CBOs, as you'll hear us refer to throughout the presentation. For the initial launch, staff members brought in patient scenarios that they were working on, and we did live demonstrations of actual situations to ensure that they felt comfortable following the workflows, both in our platform and also our electronic health record. While we continue to have trainings with similar groups like our physician residents, we also recorded a web-based training within our training portal to add all of our existing patient-facing staff and our new employee orientation package so that everybody had the training that they needed. These trainings gave an initial overview of what the platform is and how to use it within the EHR. Our platform analytics allowed us to group staff by roles and clinics to track their usage. Using this data, we incorporated monthly competitions specifically for our front desk staff and our medical assistants in order to increase searches, encourage best practices, and address concerns within specific roles. This has been crucial to take the web-based trainings and meet staff where they are with fun incentives like gift cards, stress balls, and stickers. Staff workflow begins by completing the FQHC screener for a patient. It can also be prompted when the patient mentions something to the front desk about their car breaking down on the way to their appointment or frustration with legal troubles to their provider. The teams then discuss these concerns with the patient and review what might feel helpful to them. A search will begin with the platform to find the best resources for the patient. After asking for consent to send them a text or email about the resource, the referral is then placed in the platform. Through follow-up and patient-first connection, staff members, our CBOs, and patients work together to close the loop on the referral and the social need. Now, in order to make the platform accessible to our patient population, giving them the dignity to find resources that they need, we have had various marketing campaigns. First, we started off by mailing around 7,000 postcards to a subset of our population that historically utilizes mailers. We then created highly requested stickers that are now seen on water bottles, laptops all throughout the clinics, and patients' fridges, tote bags, etc. We launched paid social media ads, which have been the highest successful advertising campaign made by our marketing team to date. We created 4 separate ads based off of the top resource searches from within our platform data, and then posted an English and Spanish version of each ad. Each quarter, we reevaluate based on the resource searches and clicks in order to identify the specific needs our patients are wanting and to market efficiently. We adjust the ad types as needed based off of the search results. Our cost is about $5 per day per ad, which in the last month reached about 25,000 Facebook and Instagram accounts. This made a greater return on investment and accounted for about 20% of the individuals that visited our site last month. As we also work to enroll more patients in our patient portal with our electronic health record, we put a banner at the top highlighting that and link the community resource platform for their ease and have everything together in one app to manage their care. So they're accessing their other health care, like lab results, but also being able to search for resources easily. Our targeted marketing campaigns were tailored to our different populations and their learning styles. We wanted to interact with our patients in a way that they would feel most connected, either through the mail, on social media, or linked already on the app. Additionally, we track each mechanism to see where our community members are clicking and scanning from, giving us some insight to adopt and tailor our marketing campaigns. Along with our marketing campaigns, our community engagement team, like Carmen mentioned, made up of our community engagement lead and most recently our community engagement coordinator, they started by transitioning our trusted CBO partners into utilizing the platform to accept referrals from us and other organizations in the community. Additionally, after listening to feedback from staff and reviewing our analytics of most common referred CBOs, we took the information to determine which of these organizations we wanted and needed to target first to transition into the platform to accept referrals. At the same time, some of the most beloved CBOs are more specialized. They're mainly helping our population living with HIV or AIDS, or assist in-home check-ins for visits with our new moms. Though the analytics did not show that these were the majority of where our referrals were coming from, transitioning these CBOs to the platform greatly increased our staff usage. Currently, we set quarterly goals to give attention to specific CBOs, either through phone calls, emails, or even just stopping by if we're having difficulties getting a hold of them. But we also encourage our staff to recommend or reach out about any CBOs they would like to see on the platform, or to forward us any information for CBOs that email them or ones that stop by in the clinic. With 441 outreach attempts in 2024, there were specifically 344 interactions and connections that led to involved trainings about the platform, explanations of workflow and timing, discussion on open referrals, and support between the partnerships. These conversations enabled us to add and highlight new programs that were not originally on the platform, in addition to editing programs for both clarity and accuracy for staff and patient understanding. During our engagement and meeting with CBOs, we also wanted to hear from them about how we could support them throughout this process. We quickly learned that not only were we needing training, but they also needed access to our appointments and financial screening visits for their clients that they were working to connect to services using the platform. This work is what we consider our phase 4, or the ongoing stage of our implementation. We want to ensure that when we're asking our CBOs to market themselves on the platform, that they can in turn also find information accurately reflected about us. In collaboration with various department leaders across the organization, our community engagement lead ensures that our information is up to date and that we're offering access to our communities through this platform. So much so that we're currently in a pilot phase of a multi-department collaboration to address access, as well as patient coverage through the use of the platform and community events. Our teams are meeting with community members in real time and connecting them via the platform to our financial screening team for live screenings for coverage and our appointment schedulers to get them established with care at our clinic. Due to our large patient population and varying access, this has been a huge leap for us, and we're extremely proud of the effort that we've made to mimic the workflows that we ask our CBOs to do. Another way to tie together the connections with CBOs and our main navigator groups is by hosting Connect the Dots events in order to continue these relationships, highlight the CBO's presence on the referral platform, and provide conversations about wraparound care. This has included inside tabling events with over 20 organizations, where staff needed to collect passport stamps from organizations for prizes, and brief community organization presentations. We've hosted outside gatherings as well, when it's not 100 degrees, and clinic conversations for resource sharing in the community. Each event, different CBOs are invited, paying attention to the current needs of the patient, but also promoting the many great organizations that help keep our community healthy. After each event, we like to give the CBOs surveys to hear their feedback about how they would adjust the events. We learned that many CBOs wanted to also spend time networking with each other so that they would also know where to send their clients to for specialized resources. We heard them and make sure to incorporate that into each of our events moving forward, as well as hosting events simply for CBO networking. During our last event, we found that one of our invited CBOs was dealing with the aftermath of a break-in. Someone had shattered their window and left quite a mess. Despite their hardship in communication that they might not be able to make it, they ultimately joined. Our staff and the representative were able to talk about how much the organization has helped our patients and express their gratitude for their work in the community. It was great, positive feelings all around. We love to share these great stories about how we found positive impacts in the community. It's also vital that we inform our decisions through our data for continued success. And as I'm sure all of you know, data is incredibly important in the public health realm, and it's been tricky to tie FQH interventions to the patient outcomes. Unfortunately, we haven't found the perfect answer, but we continue to work with the information that we do have. And we've been incredibly fortunate to gather the data and analytics from within the social care referral platform itself. As a brief overview of our two sites, we have our community site, which our patients and community members access. And then we have our staff site that all of our internal patient-facing team members, like our providers, medical assistants, CHWs, access within our electronic health record to submit social care referrals on behalf of the patient. This is 1 year worth of data from January to December of 2024. The sections that I really want to highlight here are the referrals and active users. The hope of this platform is not only that we're connecting our patients electronically, but that we're also receiving a status update and closing the loop on these referrals. We very much have work to do in this area, but we're seeing that over half of our referrals have a status update, and roughly 37% of our total referrals are closed loop, meaning that either the patient was able to get help or we know that we have more work to do to connect that patient to resources. This has been due to the great work of our engagement partnerships and community-based organizations, and also our team member workflows. So now looking at the community site and the active users we see that there are about double the amount of searches that there are users. This helps us infer that community members are searching more than once and also coming back to the platform to search again, which is what we want. We want our patients and community members to grow more comfortable with the platform to search whenever they need access to resources. Additionally, we see that patients themselves have referred within the platform over 800 times. We were pleasantly surprised by this number, as we've primarily been focused on our patients accessing the platform and searching within, but we haven't provided much education for how to submit these referrals on their end. We're hopeful that this can lead towards increasing awareness, knowledge, and ultimately guiding our patients towards FQH self-management and autonomy. Our analytics also give us insight as to what our patients are searching for and what their needs are so that we can tailor interventions and partnerships to the needs of the community. Our community engagement team gathers this data along with staff feedback to inform their work with CBOs and who our quarterly priority partners are going to be. We see that for both of our sites, food, housing, and health have been the top 3 domains for needs within our community. And we've built partnerships like with Central Texas Food Bank and the local housing authority and other organizations to help support these needs. Historically, transportation has been in the top 3, but our data has shifted within this past year. This helps us take a look at the bigger picture and prompts us to evaluate what may be going on in the state and local levels, like maybe Medicaid disenrollments, as well as assess the resources available within the community, and then advocate for additional funding within our organization as needs shift. We've also been pleasantly surprised to find the regional impact that our platform has brought. Although our paid social media ads are targeted to our nearest communities, we found that they're reaching a huge audience, along with the patients from all over Central Texas that visit our clinics. Again, this data helps us target interventions and partnerships to the zip codes with the highest level of need. For example, with our partnership with Central Texas Food Bank and the Mobile Food Pantry, we can move services to the clinics within these high-need areas. I'll pass it back to Carmen to talk about the benchmarking data.
Thank you, Clarissa. We felt that we were doing a wonderful job of implementing the social care referral platform, but we wanted to understand how we compare to other similar organizations and the use of the platform. This table here shows 2 other organizations, both with similar electronic health record integrations. One is an FQHC, and the other is a large hospital-based health system. We are also seeing data for both staff sites and community-facing sites combined. we find that even with about half the users as the hospital system, we still see over 26 times the amount of social care referrals placed. This shows us that our engagement efforts with our staff, patients, and CBOs has really paid off. We couldn't have had this success without our team members dedicated to these efforts. Overall, our data shows our success within the platform, but it also underscores the need that there is in our communities and the work that remains to be done to address these needs. We'd like to conclude by sharing our lessons learned. Do not underestimate your patients' ability to use technology. Our patients have learned to be resilient by nature of all the hardships that they face on a daily basis. Marketing is critical. Consider your audience when deciding on methodology. Older adults will likely respond to mailers and postcards, where young adults are more likely to leverage technology. The role of the community engagement lead is critical to the success of the platform. I sincerely believe that we would have not have been this successful without the role of the community engagement lead. Consider the needs of CBOs when engaging in outreach, assess how you can respond and address them. And I close with the criteria and components evaluated during platform selection. Is the platform widely used in your service region? Is there robust data and analytics? Is there a high level of integration into the electronic health record? Does it support maintaining and updating the CBO listings as well?
As we transition to the Q&A, please scan the QR code and see all the wonderful resources available in our communities. Thank you so much for joining, and what questions do you all have for us?
Thank you, Carmen and Clarissa. I'll ask the audience to please drop questions you have into the chat or raise your hand. And I will kick us off with a couple of questions that we had already posted. The first question we had comes from Merla Lopez. Merla, do you want to unmute yourself and ask your question?
Yes, I was having some connection issues and I heard you say it at the end, but I didn't hear the whole thing. How are you defining a closed loop referral?
I'm going to bump that one to Clarissa.
Yeah, so and I think there was a document added to the chat. You can reference that as well for some specific definitions. Okay. But sometimes it's not just, was this resource successful? It's also maybe, did the organization run out of funds and they weren't able to provide us information? So that still is essentially them giving back the information about what happened to the referral. So either was it successful or was it not, and do we need to continue inserting resources for this patient? Hopefully that answers your question.
It does. I was just, because I've been in, we've been talking about closed loop referrals for a couple of years now. And I was just, when we talk about closed referrals, I think we need to just break it down. What is a positive closed referral and a need to work on closed referral? Because I would love to see more of those numbers, because then it ends up being like this amount of closed referrals, but what percentage were positive addressed referrals?
And Merla, you'll find that the documents that are shared in the chat, we worked in collaboration with other organizations within the Austin-Travis County area so that we were all using the same terminology, because that was really important. At the end of the day, we're all doing the same work, and we need to be speaking the same language. So you'll find other organizations that are using the same terminology, and we were very purposeful in adopting that same terminology. I will say it's intuitive, and it worked and served our needs well.
Thanks for that question. Next one I have on my list is Dr. Chiquita Collins. Dr. Collins, do you want to unmute and ask your question about cost?
Sure. Nice to join you again this week. I'm not sure if I missed it, if the community-based organizations are responsible for contributing any type of financial dollars to support this endeavor to market their services. And then the second part is, the community-facing events, we try to be very unique and go to where people are. not always in terms of our clinics and other types of associations. And so do you work with, for example, the school district? Because that's where we get our parents and families.
Yeah. So there is no cost for our community-based organizations to promote their resources, to have their information on the platform, and even for them to use it as essentially a work queue of working those referrals that are coming in. So it's completely free for the organizations. Of course, you know, we have a cost as we have our own branded sites, and that's integrated into our electronic health record. But the benefit of the platform that we selected is that it was going to be more broadly used because of that free cost for our organizations. And then, you want to?
Yeah. One of the strategies for the community engagement lead is to be out in the community as well. So they will go out to the sites. They'll attend community events as well. So they do go out and meet the, you know, the CBOs where they're at, because we know there's some CBOs that are volunteer run and so on. We have some presence in certain schools where we're also providing care. That is another area that we want to expand into. As an organization, we're making connections with additional schools to provide care so we can see them using there. I will say that the community engagement leads are very proactive, so you'll find that they'll go and they'll put our flyers at different libraries and make connections with folks in those libraries in our area as well.
Thank you.
I see another question about the integration phases from Clara Ann Cromer. Clara, do you want to unmute?
Sure. You talked about the different phases. You got phase 1 through 4. Just curious about did you predict how long each phase was going to take? And if you did it kind of match up with what you thought was going to happen? How did that estimate of time work for those different phases?
Let me take that one. Okay. We were very pleasantly surprised with the adoption. Frankly, for me, the assessment of all the platforms felt like it took forever. But you're going to find that individuals that work in these healthcare settings want to help people. They're hearing these needs from the people, and this finally gives them something that they can do about it. I think all of them pretty much matched the timeline that we had said. I think we have been surprised at how quickly phase 4 is just intuitively moving, because we felt that that was going to be the longest phase to really incorporate, only because demand and supply for the services that community health centers provide, you know, are not balanced. The demand always exceeds the supply, but we're much further along in that stage than I expected us to be, which I think is good.
Thank you. Continue to raise your hand or drop questions in the chat. Another question I saw was, you know, you described a really comprehensive set of processes to reach all the folks that need to interact with this platform to make it work. But the platform itself, I'm wondering, you know, we keep hearing about how artificial intelligence is going to be changing, you know, healthcare. Like, how do you foresee AI as like kind of changing what the experience is on the platform?
I'll be really honest, we haven't assessed yet how it will directly impact the platform. As an organization, CommUnityCare is assessing AI's impact in general across the board. The hope is that it would be positive and that it, you know, expand our reach.
Great. And kind of as this program evolves and you continue to learn from it, how do you foresee the evolution of this project? What changes do you see on the horizon?
You want to go first? I know we both have ideas. Yeah. I think for me, it really is that phase 4. I want us to be able to connect patients to our services much just promptly and with less barriers. While I think I'm satisfied with our closed loop percentage. I want that to be higher. And I want, our frontline teams, and when I say our frontline teams, I mean like our providers, our medical assistants, our nurses, a MAC, a financial screener, a pharmacist. You know, we made it to where they can use those tools, but I think that we also need to focus in maintenance. So now we're using the data available in the platform to say, you know, this unit, this internal medicine unit has consistently been using the platform and we're seeing a dip. Maybe they had some turnover and we need to go back and provide them some support and training. This other unit is consistently using it. Let's give them some recognition and kudos. We just got to keep it at the forefront, because our goal as an organization is that every interaction, regardless of who's involved in that interaction, is having that interaction with a social care lens. Would you add anything, Clarissa?
Yeah, I think to just build on that, one of the things that we've been very fortunate is to grow our community engagement team to now to 2 people, and I want to shout out to Claire Ann, who really helped us with the implementation. And with the addition of this additional person, this coordinator, we've been really able to focus and expand the community engagement piece of it and really build and establish great rapport and relationships with our CBOs. And through doing that through the platform, but also just expanding the maybe like coalitions and working together to really improve community access to resources and having this common goal of the platform to bring us together in that. So I think that's where we're also expanding our phase 4 or ongoing phases of the platform. Thank you.
So going back to the implementation plan, you know, you had a very, thorough process that you ended up developing with a lot of components. You've already talked about how phase 4 is something that you're reimagining now that you're gaining experience with it. But how did you develop that plan in the first place and come up with just all the components that fed into it?
I think when we first started the Find Help assessment, it was myself as a nurse and another nurse and kind of operations folks that were assessing the platform. And we realized that we needed to bring in the folks that were closer to the work, the lens that Clarissa brings as a social worker. So we incorporated her to the team. I don't know that there's necessarily any experience that we've had, and then really staying close to the team and what they needed, what CBOs they thought were important. What we had to make it easy for all of those individuals to do the right thing by the patient. When you look at a community health worker, our community health workers get so many referrals. A provider has to see so many patients. An MA has to intake and discharge. And if you're a health center, there's so many grants, requirements, and so many things that you have to do. So we focused on supporting and making it easy for the folks to do what we know that they want to do, which is support the patients. And I think that drove a lot of the decisions and how we incorporated it. Would you add anything else?
Just to add, I think that at health centers and just organizations with a lot of stuff going on, everything is a pilot. Everything starts off as a small pilot, and we build on from there. So, of course, we started with our CHWs and these roles and wanting to kind of see how that went for a little bit, but then quickly we added other providers and team members who were really excited about this work and really wanted to participate. We got some really great pilot participants and providers who were really championing this and kind of led into those additional trainings and phases. But yeah, it starts with a pilot.
Yeah, your timeline really reflected that just organic growth that just, each success builds on the next one to bring it all together. I was impressed with how responsive your social media campaign is to kind of reflecting, the recent needs that you're seeing. And I was wondering, that sounds labor intensive, but like how much time does it take to kind of revise those and come up with the new set each quarter?
Yeah, we partner a lot with our marketing team, and sometimes it's small adjustments that they have a lot of understanding and background of what works and what doesn't. Sometimes it's changing the picture of the food that's on the ad, and then it helped increase the clicks and usage. But really, we look at the progress about once a quarter, and we run those regularly, and it kind of just goes on its own, and we change as needed. But it hasn't been as much once we got those initial domains that we really wanted to focus on. So for our 4 domains was food, transportation, health, access, and housing. And so we just kind of slightly change as needed, or changing for holidays, things like that. So it sounds like a lot, but it at least from my end, I'm sure the marketing team might have other views, but from my end, it's been a pretty seamless process.
I think what I would add to that is the team is very purposeful in any material that we create, whether it's a flyer or an ad, that we use visuals. We always consider reading grade level, and it's all informed by the data. So I think that helps to make it successful. I also feel that when you're talking about social needs, there's a certain degree of dignity that the individual can keep and hug to themselves when it's behind technology. So if you have something you can click and connect to a resource, you're probably more likely to do that than have to tell someone that you're struggling with this resource. So I think that probably has some of the success, attributes to the success.
Well, it's really striking just how kind of intentional and proactive that you've been able to be in each of the steps of this, in the context of, like you said, we're all in healthcare, feeling very overscheduled and very busy. So that attention to detail, I think, is reflected in the successes that you're having. I see there's a question from Trina Jackson. Trina, do you want to come on mute?
My question is, how long would you keep a case open if the client does not receive the services? The reason why I'm saying that is because we have a lot of housing issues. So some of those cases can be open for a very long time. Food is not that, but when you're looking for housing, those cases can run a little bit long. So I wanted to ask, how do you navigate that, and how do you kind of keep the clients engaged while you're trying to help them stay on track first with their health and to help them get proper housing? So I just wanted to ask that question because I'm listening and looking at the referral.
That's a fair question.
Yeah, so housing, definitely very tricky. I think that our CHWs do a lot of this connection to resource. And so sometimes if they are referring within the platform, sometimes until that organization is able to get to it, or if they have funds or whatever, sometimes it might stay there for a long time, unfortunately. And it might be an open loop referral. It's not, or an open referral. It's not going to be closed loop for the meantime. I think that what we do, particularly for housing, because that one is probably the hardest to address, is we have an ongoing list of our patients that are needing this type of assistance, and we scramble very quickly as wait lists open or as things come, funds come available. We quickly reach out to those patients, and the list can be growing for a long time. But we also, because we know that as a health center, we're unfortunately not able to meet all of the needs of our patients, we do our very best to make sure that we're making connections to these community organizations that might be able to meet the need. So even if, let's say, they're on a list for a long time, or in Austin, we have ECHO, which is the Ending Chronic Homelessness Coalition. So making sure that they're connecting to those organizations who will be hopefully able to address them soon. But that has been a tricky thing to manage.
I'll add two things to that. In regards to engagement, we're fortunate in that we're a health center, so there will so often be coming into the clinic to see the provider. So you kind of have a captive audience, whether, you know, by free will or not. So you can check in with them that way. I think another strategy that we've used for housing and transportation is dividing it into two little buckets. The first one is, what immediate need can I address right now? You know, maybe it's providing shelter information, whatever it may be, and then address that immediate need, and then start working on the longer term need. Housing, we feel that is one of the hardest ones. You know, so much that, you know, when you screen, that's probably one of the things that your team members are going to say, why am I screening for this if I can't really do anything? So you kind of have to help them work through that.
Thank you. I appreciate it.
Thank you, Trina.
I see it. There's another question in the chat from Vishnu Nepal. Vishnu, do you want to unmute?
Sure. Can you hear me okay?
Yes.
Okay, great. I had written one question earlier, probably you missed that. It's okay. And then I added a second question too. What's the platform built off of technology-wise? Is it SQL or some other platforms? Then the second piece is how can I know it's built for the purpose of Austin area, but is there any opportunity to leverage that in the Houston area as well? I'm with the Houston Health Department.
Okay. I'm not sure exactly if I understand the question of what it's built off. I can tell you that as part of our contract, we made it to where we have access to SQL data
Okay.
because we feel that having access to that SQL data, and I always oversimplify this in my mind. You know, I'm sure someone more technical than me knows it's not exactly how it would work. But we were very purposeful in wanting the SQL data because, in my mind, I should be able to combine that SQL data with the information in the health record, and that gets us closer to, you know, the dream of anything around non-medical drivers of health, and that is to be able to speak to how this social intervention impacted this health outcome. I think that was where we, and
yeah, so we use Find Help, which is integrated into our electronic health record, which is Epic. And yeah,
Okay.
so again, we don't endorse any specific platform, but Find Help does have a national reach and resources within every zip code in the United States. So that was a part of our platform selection, is making sure that because we have patients sometimes who move to a different city or move across a different state or are temporarily somewhere else, that we can connect and find resources within that zip code. Yeah.
Okay.
did we answer both your questions?
The second part, I don't know. This is really focused on Austin area, right?
Oh, no, it is based out of Austin, their headquarters, but it is not an Austin only platform. So the organizations that we compared in our benchmarking data are actually not in Austin, they're across other states.
I mean, Find Help is a national
Okay.
company.
Okay.
Yeah.
That just jogged a thought I had when you were presenting about the benchmarking, which is really powerful information that kind of gives you context to know where you're at relative to others. I'm wondering, like, when you take that benchmarking, especially to your leadership, you know, what kind of questions do they have and how do they respond to that benchmark data?
They didn't have questions. I can't think of it. They were very happy, but we were able to obtain commitment that the positions, which are, all of this is grant funded, the commitment to roll them into the operational budget, both the platform and how we pay for the platform annually and the positions. So once they said that, we had we were like, okay, thank you, no more questions. But yeah, it was very well received. And it's, yeah.
Yeah, I think just to add to that, we requested the benchmarking data because, we thought we were doing great, but we honestly had no way of knowing how we were doing. And so when we requested that, we were extremely surprised and very pleasantly surprised to receive that. So I think for us, it was
validating for
yeah.
Well, and I think that speaks to this, just the idea of evaluation, which is something the consortiums have really been focusing on this past year. When you're first rolling out something new, a lot of focus is on evaluating and measuring like the processes that you're delivering, are they working? And then now you're talking about like kind of that second step of like, how are we performing, relative to others. And that's so important for sustaining that work. And, like you said, you got a payoff out of showing that.
We did.
And then like you alluded to earlier, the ultimate goal here is connecting that back to showing the health changed of all this.
Yeah, for sure.
Well, we're getting close on time. We probably have time for one more question. If anybody has as an item that they didn't hear an answer to already, if you could just raise your hand, we'll get you fit it in real quick here.
And while we wait for that, I just wanted to note that I'll plug in our community site as well as our emails in case anybody has any additional questions after we end here.
Yes, we're very receptive to anyone reaching out. One of the best measures of success is for other folks to be able to replicate this work and have an impact in their community. So please don't hesitate to reach out.
That's one of our goals as well, is that we can bring peers together and learn from each other. Dr. Collins, you get the last question.
Comment, outstanding work, and for you to blow out of the water a federal qualified health center and a hospital, the data alone, if your company or organization did not incorporate into their operational costs, then boo-hoo on them, but outstanding work. Thank you so much for the presentation, quite informative.
Thank you, thank you.
Thank you again, Carmen and Clarissa, for this presentation, for everybody sticking on and engaging in this conversation. I'm going to turn it over to Jackie to close us out.
Thanks, Charles, and thank you very much, Clarissa and Carmen, for this robust conversation. These convenings are important to advancing NMDOH work in Texas. But before we wrap up, I want to invite you all, the healthcare organizations in the webinar today, to be a part of our growing NMDOH program index. For those of you serving patients at healthcare organizations, we want to hear how you are meeting patients' non-medical needs through non-medical interventions. We're looking for health systems, hospitals, clinics, and health plans. This is an exciting opportunity for you to showcase the various ways that healthcare is already addressing patients' non-medical needs in Texas. The index is a resource for providers to learn who is doing what for which patient populations, and we also hope it can be a resource for policymakers to see how the healthcare system is meeting patients' non-medical needs and make policy change in favor of sustainable payment mechanisms. The program index is only going to be as robust as we make it, and I look forward to connecting with each of you who fit the criteria. The program index link is in the chat. Please click it and review to add your information at a later time, and you can always email me at jk90@rice.edu. Thank you so much for taking the time to join us today, and please look out for the meeting materials in the coming days. We will include a link for you to suggest future webinar topics and encourage you to tell us what you want to learn about next in the field of practice for the non-medical drivers of health. Thanks again, everyone, and have a great day.
Thanks, everybody.
Thank you.
Thank you.